This conference will now be recorded.
And I'm going to run through the list again. So I see Rich Jackson, Ron Miller, Jake Hannum, Les Shelderup, Len Sierra, Carl Foreman, John Appler, Jay Curran, Jerry Pelfrey, Peter Kafka, Dennis Correa, Sylvester Mann, Bill Franklin, and Ozzie Smith. Did I miss anybody?
No.
Good. All right. So we have two new folks, at least new to me. We have Ron Miller, who Ron and I have been talking a little bit for a while. And so I have a sense. And Ron, I just have to say that I just called Bill Burhans and he is not doing well right now. He's in the midst of another UTI. And so I was hoping to get him on the call with you, but unfortunately, it doesn't look like he's up for it. So I am sorry, but you guys will definitely connect at some point, but that doesn't mean to say we don't have more wisdom and knowledge for you on this call. And then
at home.
He's at home. He's trying to avoid going to hospital. He thinks it's a little more serious because there's some blood involved. But I will call him tomorrow and see how he's doing. You know, it's just miserable. And it's a similar situation to what Ron Miller finds himself in. So we'll talk about it a little bit more when we give Ron Miller some time coming up. And Ron, I want to allow you to get into the house and so you can get settled. And we have one other new gentleman, I think, which is Ozzie Smith. Have you ever been on the call before?
No, this is the first time.
Well, welcome. And you're a brave man because we see you for the very first time. Most people won't do that the first time, so thank you.
I should have done my hair.
That's okay. That's what Bill Franklin said, but we forgave him. What we usually do to begin with is we like to go to people that have never been with us before and give them some time if they're comfortable. And if you are, then tell us a little bit about what brings you to the call and what your history with this disease is, and your experience, your treatments, and how we can help you. Does it work for you to kick us off or not?
No, I can do that. That's fine.
Thank you.
Obviously, everybody knows that I'm Ozzie Smith, 65. Was first diagnosed with prostate cancer over a year ago. Went through the rising PSA. Finally did some biopsies that all came up positive. Decided to go with HDR brachytherapy. I imagine most of you are familiar with that, where they actually put little radioactive rods up where the sun doesn't shine, and
right.
But they pull them right back out. This isn't the kind where they leave seeds in. This is the kind where they just expose you to high radiation. And given that my prostate cancer was fairly minute as far as Gleason scores and everything, it was supposed to be kind of a simple in-out sort of thing. And of course, like everything, that never quite happens. And my PSA never really went down. It got up into the 10s, and then right after the radiation, it dropped to 2.5 or so, but it's promptly started climbing right back up again. And urologists and oncologists are not on the same page. Urologist was all but giving me surgeons in several different states, you know, Mayo Clinic and one of the things up in Salt Lake City, and all but saying you're probably going to need a prostatectomy here pretty soon. And but in the meantime, how about we give you a contrast MRI? And the oncologist thought it was too soon for that. But I thought, well, you know what? We'll take the test because with contrast, and my numbers were still below 4, which is supposed to be fairly sedate and nothing. But of course, the MRI showed a shadow and said likely. And so I thought, you know what? I better start finding out all I can.
Mm-hmm. Mm-hmm. And so when, let me see if I can fill in a few gaps for my guys here. First of all,
Sure.
where are you? What part of the country are you in?
I'm in a little burg called Mesquite, Nevada. It's about an hour and a half northeast of Las Vegas. It's
Okay.
right there near the Arizona-Utah border.
Okay. Okay.
And
Yeah,
all
I
my
have
doctors happen to be in Utah, in St. George.
okay. I know St. George. Okay.
I know St. George also. Yeah.
Oh, do you?
Yes.
Okay.
I've hiked in Zion several times.
Okay.
All right. Me too. Me too.
Yeah, that's a cool place to be.
Yep. St. George
So
is
yeah,
very cool.
I've been up to the top of Angel's Landing 3. So
3 times?
so yeah.
Only once for me.
Yeah. Only once.
Uh-huh.
Yeah. So yeah. So I am familiar with it, and for those of you on the call who are not, I can only say you should be, because for me,
For sure.
Zion is the most beautiful of all the national parks that I've seen in this country. It's just remarkable. So anyway, I'm kind of familiar with roughly with the area. I'm a good way south of URC. I'm down in just north of the Mexican border in Arizona.
Okay.
So your docs are in St. George. You mentioned an oncologist. Was that a local oncologist in St. George that you saw?
Yes, both the oncologist and the urologist are out of St. George.
Okay. And then what was your PSA was 10 when you had treatment? That was the high before you started the treatment. What was your Gleason score?
I believe it was a 6.
Uh-huh. So that's also kind of interesting. And so you had HDR brachytherapy. Your PSA dropped to around 2.5. They did an MRI, and there's some sort of a shadow. Where do they see that shadow?
I haven't talked to the doctors specifically. I assume it's somewhere near the prostate, on top of the prostate. I haven't got it geometrically placed yet. My next appointment's not until July, so I'm real thrilled about that. But that's the way things turn sometimes. So don't really know.
Okay.
I don't have the films for it. I may go ahead and get them. I called the doctor today, and they didn't seem inclined to switch appointments or anything like that. So, well, okay, maybe I need to find out even more yet.
So when before you decided on HDR brachytherapy, what other treatments did you consider, and why did you choose the HDR brachytherapy?
Well, my theory was, let's get this done. This seemed to be the less invasive, better chance for success. Watchful waiting, I was just watching my PSA climb out. Also, like I mentioned, the biopsies already indicated there was cancer present.
Right.
So it was kind of that, or, the proton beam seemed a little bit more like a club than it did seem like a surgical instrument. I don't know that to be true. It's just what my take was on it. So I apologize if anybody of you had that done, but it just seemed like this was I won't say easy because it was anything but easy. The lesser of evils is probably the best choice that I can say.
Okay.
Now,
So
has all of you here gone through prostate surgery of some sort, or just has prostate cancer? Or I'm not sure where my group stands as far as experience.
well, I think this group has been through both types of brachytherapy, and they have had surgery. Some of us have had surgery, some of us have had brachytherapy. I had low dose seeds. I'm sure there's somebody on this call who had high dose, has had high dose. I can't remember. John Appler, did you have high dose or low dose? I can't remember.
Yes, Rick, I had high dose HDR in San Francisco.
Right. So we've had people with high dose, people with low dose, people who have done surgery, and we've probably had a few people who the disease has come back on immediately, and then we've got a bunch of people who have fairly advanced disease on this call. I have a couple of ideas for you, but before I share them with you, I'm going to throw it open and let some people talk to you a little bit. How did you find out about us, by the way? Was it through the Us2 website?
Yeah, I was just trolling for information, trying to find out anything I could, and stumbled across it and said, hey, this looks like it might at least be a place to check out.
Well, one of the reasons we started this was exactly for people like yourself who are in pretty remote locations, so that for you to be able to get to a physical support group is pretty difficult.
Yeah,
so,
exactly.
Yeah, we recognize that. So let me throw it open. Who would like to start, kick off the conversation with Ozzie Smith and talk to him a little bit about options at this point in time?
RC,
Don't chime in all at once.
yeah, RC, I think you said you had very low tumor burden and it was confined within the prostate. Is that right?
That's exactly right.
I don't think HDR is the typical go-to choice of therapy, but I think in your case, most docs would either have done surgery or something like SBRT or IMRT radiation. But I mean, that's all water under the bridge at this point. Just kind of surprising that after the procedure, your PSA didn't go to 0, especially given that your Gleason grade was only 6. Are you with us now to try to seek advice or suggestions on what to do next?
Yep, that's it exactly. Like I said, I'm not getting a clear picture of what to do for my doctors. Thinking it may be time for a new team even. Whenever you have two doctors that disagree, you need a referee somehow.
What's the nature of the disagreement? What are they each saying?
Well, the one is saying just wait and see. He's the patient sort. And the other one is all but saying get everything done now that you can while you still can.
Mm-hmm.
So I've got really the equivalent of a devil and an angel on my side here, or whatever you want to say. It's two very polar opinions.
One of your doctors is a urologist, you say. One is a medical oncologist.
Yes.
But isn't there a radiation oncologist involved?
Well, that's what. Yeah, he is a radiation oncologist. The oncologist that I have is also the one that did the procedure. Okay.
So what you're calling as a radiation a medical oncologist, or an oncologist is the radiation oncologist. So you have a urologist and a radiation oncologist.
I'm sorry, you dropped out at the end. I missed you.
You have a radiation oncologist and a urologist on your team right now.
Exactly.
Is that correct?
Yeah.
Okay. So Len, what would you do if it was you in that situation?
Right now, with a PSA of 2.5, I would.
I'm sorry, my PSA has since gone up.
Oh, what is it now?
They had me try some experiments in late February. It was 3.7. In just a couple weeks, 3 weeks later, it was 3.9. The urologist asked for that second one. He wanted me to try some different things, and it continued to increase anyway.
I think one of the things I would do is get a second opinion on your pathology report on the biopsy, because this seems a little surprisingly aggressive for a Gleason 6.
Yes.
The other thing is, might want to consider getting a scan. One of the most sophisticated FDA-approved scan is Axumin.
And what now?
Axumin, Axumin. And with your PSA at that high a point, Axumin should do a good job in defining where the lesion is.
Okay. I think they've got a pretty good handle on where the shadow is. They just haven't had a chance to share it with me yet.
Oh, okay.
I imagine that if I asked for the films, I might even be able to tell. I just haven't been able to get to that. This is all fairly new to me.
Yeah, I'm still thinking second opinion is.
Oh no, I'm definitely after a second opinion. I'm just trying to decide where to get it from.
So yeah, so maybe I'm getting too far ahead already. But if they have the lesion clearly defined, it seems like something like, well, I was going to say SBRT radiation, but I know there are warnings against radiating the same area more than once. I don't know, Rick, maybe you know more about HDR brachy than I do. Isn't it kind of surprising that they didn't bring the PSA down to 0 and that there's still something there? Does this suggest that the rods weren't placed very well?
You know, I was just thinking something along those lines. RC, what sort of imaging did they do before you had the HDR procedure?
They had some pretty good imaging. They were able to show me. They did some placements. First, they did a couple different, I don't know what you would call them, marks inside of me in order to act as guides. So when they were doing it, it's pretty high tech, computer controlled, everything, you know, run on by computer scans. I've got photographs of how that went into me. I might even have them around here somewhere.
But before they put you into the procedure room, what imaging had they done? Had they just done an ultrasound to?
They just done the biopsies is all.
With the ultrasound.
I assume that it was guided. I can't remember.
Okay. I mean,
Rick?
had you had an MRI or a CT scan before?
Not prior to this last one, no.
Okay. So, yeah, I mean, I would sort of tend to say the same thing that Len is saying, that it does seem a little strange why they jumped in with HDR based on what they saw. How many, do you remember in your original biopsy, how many cores did they take and how many cores were positive?
I think it was half a dozen cores, 3 of which were positive, 1 of which was iffy.
Okay. So, you know, it's a kind of an extreme treatment for that type of diagnosis. Like Len says, it's done. But I'm going to I'd like some other guys to chip in, but before we move further, I'm going to recommend a doctor for you right now in Vegas who is really good, really good. And he's a medical oncologist. He's a genitourinary medical oncologist, which means he is, he's not a surgeon, he's not a radiation guy. He's the sort of guy that you want to be talking to now to figure out how best to follow up. Doesn't have an axe to grind, and he is outstanding. Now, his name is Nicholas Vogelsang, and if you look in the chat window, I've put the link in the chat window for you. So you can just click on that link in the chat window and you'll pull up his face and his spelling and where he is and all the rest of the good stuff.
Got it. Thank you.
There's another really good resource in Vegas. He's a patient advocate and probably one of the best. I would say he's in the top 3 patient advocates in the country. And he runs the Us2 group there.
He runs the what group?
Us2. Are you familiar with Us2? Yeah.
No.
So, no. Yes or no? No.
No. Sorry.
Okay. So I'll put that. I'm going to put that for you in the chat window too. And Us2 is the organization that provides support and education. And we're affiliated with them. We're approved by them. We're their virtual group.
Okay.
And the guy who I'm going to refer you to, I'm going to tell you about is Tony Crispino, Crispino, Crispino. And you can tell him that we sent you, that Rick Davis sent you, and I have a email address for you that is associated with your name on here. Is that a good email address?
It's kind of a blowaway email, but I monitor it daily anyway, so it's fine.
Okay, so I'll send you, if you have a better email address for me, you can send it to me when I send it to you, but I'll send you Tony's details, and I do recommend you give him a call. You'll find him he's very tight with Vogelsang.
Okay.
They're good buddies, and they work in the Southwest radiology group. There's a group of doctors that are affiliated in a trial group, as it were, and Tony's part of that, as is Dr. Vogelsang. And my feeling is that you want to show Vogelsang your MRI, you want to show him the ultrasound from before, you want to get a copy of the procedure report from the radiation oncologist. Ask the radiation oncologist for, I don't know if it would call it a surgical report, but the equivalent of his surgical report. Have all that information, make a time, and take a drive down to Vegas and sit with Dr. V.
Yeah, this is Bob.
Can somebody can we mute Jay Curran just for the second, and then we'll bring him back on in a minute. There we go. Sorry about that. So does anybody else have any suggestions for RC?
Hi, Rick. John.
First of all, John Appler, and then Peter Kafka. John, go ahead.
Yeah, sure. RC, welcome to the group. I, like you, also had HDR, and I hope you do see Dr. Vogelsang right away. My PSA became undetectable after my HDR, as did many people, I think, on this group as well. So I think you are very correct into seeking a second opinion, and I hope you do see Dr. Vogelstein right away.
Okay, thank you.
Peter?
Yeah, I would caution you, if it was me, to be real careful going after surgery post HDR brachy. I don't know of anyone who's done that, and I think if that's the way you end up going, I think you want a surgeon who's had experience with that. I don't know. I mean, I know they caution doing surgery after IMRT radiation. I don't know what the situation is with HDR brachy, doing surgery after that. And also, I'd mention that I did recently, last November, I did proton beam radiation for a recurrence for in my situation, going after some lymph, and it might sound like a club on one level, but I know you guys, there's several of us on the call tonight who had proton beam and found it very effective. We did mine down in San Diego area at California Proton Center.
The follow-up proton is what you're referring to?
Yes, yeah, I'd follow up proton, but I had IMT and I've had surgery as well. So I've been through the gamut of it, but I just be cautious about the kind of medical care you're going for if you're going to go for further.
RC, this is Jake. Did you say your doctor told you to wait until July to come see
Yeah,
him?
well, that's when my next appointment is, yes.
Was that before or after they saw the MRI?
Well, the appointment was set up before. I just called them today, said, hey, have you had a chance to take a look at my MRI yet? Now, admittedly, I'm just talking to the receptionist. And I said, has he got anything to say? He says, well, she may have been acting as filter. I won't pretend to know what her role in this was. But she said, oh, you've got an appointment in July. That's when he'll talk to you. And she seemed to be under the impression that he had looked at my MRI. So, and in all fairness to the oncologist, he's been pretty good about calling me back on things. So I was a little bit surprised by this one. Little bit concerned that he may be getting close to retirement. I don't know that to be true, but when you start looking in the shadows, sometimes you find some.
Yeah, that concerns me that they're telling you to wait until July if they found something on the MRI. You know,
Yeah.
If I was you, I'd insist on talking to the doctor myself.
Okay.
Say, what did you know, has anybody mentioned anything like Lupron to you in the meantime?
What was that word?
Lupron or Permagon? You know, it's a shot that basically brings down your testosterone and stops cancer from growing if you actually do it.
Okay. Yeah, that seems to be one of the things that is the alternative to surgery is hormone therapy.
Oh, okay. I'm just curious.
RC, this is Rich Jackson. I had HDR also.
Okay.
They didn't do any scans before they did the HDR other than the biopsy?
I'm trying to remember all the different things. I've been putting I was awfully trusting in all of this process because I just thought I had a couple guys that knew what they were doing and it was going to be within their framework fairly simple. I can't speak to that right now.
Okay, because the HDR it's a surgical procedure. It's a precision surgical procedure as far as placing the radiation.
Yeah.
So they have to know where it's at so they can put it in the right spot.
So that would be my assumption as well too, is that they've done all that.
And they also have to determine what size it is so they can determine the dose that they want to apply to each particular location. And they wouldn't, you'd mentioned something about they placed markers also?
Yeah, well, that was for the HDR for me. I don't know how it was done for you guys. It was done over 3 sessions, not all done at once. They're roughly 2 weeks, 3 weeks apart.
Okay.
Wow. I've heard it done over. And this was with the rods through the peritoneum.
Yes.
I've heard it done in 2 sessions, usually overnight.
Mine was one. Mine was a single session.
Right. More recently, they went to a single session, and now between 1 and 2 sessions. So, but I've never heard it done in 3 sessions that far apart. So the whole thing sounds a little screwy. I mean, I think your best starting point, I mean, that's really weird to me. I think the best starting point is to reach out in the morning and make an appointment with Vogelzang as soon as you can.
Okay.
Because I feel strongly that he's very good, he's very reliable, and he's going to guide you as to what your next best step is. And he's maybe going to understand what the thinking was behind what was done, because to be honest, I'm not too sure. The other thing is, talk to Tony, tell him that you're going to see Vogelzang, and see if he's got any other thoughts that he has, because he's going to know the resources in Nevada better than I know the resources in Nevada.
Okay.
And that's why I'd like you to talk to him. And then if Vogelzang says, this is who I think you should see, and this is what you should do, you can bounce it off Tony as well. I mean, you can choose if you want to talk to Tony before or after, but you definitely should. And I've sent you, just to you, I've sent you Tony's telephone number, and I've sent you his email address.
I saw that, and I've got a copy of it.
Okay, so his telephone number and his email address, you have Vogelzang, you have, and if I have a moment, I'll drop Tony a line too and tell him to expect to hear from you.
Okay, thank you.
And, I think that probably that's the best we can do right now. I do, depending on where the location of that additional shadow is,
right,
determine to what extent what your next treatment should be, and we can't tell you. I mean, if the shadow,
no, I understand.
I mean, if it's when I say we can't tell you, we're not going to give you medical advice anyway, but we can tell you what we might do if we knew where the shadow was.
Right.
And if the shadow is totally inside the prostate, that's one thing. If it's outside the prostate, that's another thing. So we don't know. But I mean, some of you guys on the phone may have heard Vogelzang speak at PCRI. I think he was there 2 years ago. But he's very, very reputable. The only other resource that I know of when you're ready for it is, I know a very good integrative oncologist also in Las Vegas. But I don't.
That was one of the primary things I was hoping to find out here, is somebody that didn't just confine their thoughts to surgery, the other things like meditation,
right?
Health,
Okay, so I've got to find his name. I think, and I'll let you know, I think we have a link to a presentation. He did a presentation for us. I think it's on the new website. And let me just see if I can find his name for you. He's a really good guy. And what's his name? Vogelzang knows him. And I would, but, I think that Vogelzang has to be your starting point at this point in time. I want to say Lavender. Hold on a minute, and I'll give you his name. His name is Hikal. I'm sure it was with an L.
Well, you can just email me.
Yeah,
RC,
I'll email it to you.
while Rick is looking it up, I might want to make a suggestion.
Sure.
Take a recorder with you so you can catch all the nuances of what your doctors say.
Okay.
They don't,
Will do.
as long as they know that you're doing it, they normally don't have any objection. And
All right.
I found it very useful.
Okay.
So.
Will do. I like it.
Okay, I'll send it to you as well. I can't find it off the top. I thought his last name began with an L, but evidently it doesn't, because he's not in my doctor's list in the right place. So I'll find it to you and I'll send that to you as well. But right now that's secondary. The first thing is to go see Vogelsang and then use Tony as a resource in Vegas.
Okay.
Okay. And then,
Appreciate
come back. We'll add you to the, I'll add this email to the address our distribution until you send us something else, and come back and talk to us some more,
Okay. How often
Okay.
do you do this? I didn't notice.
We meet weekly.
Oh, okay.
We meet on the first and third Mondays at 5 o'clock Pacific, and we meet on the second and fourth Tuesdays at 3 o'clock Pacific.
Okay.
Okay? And I'll be in
Hey,
touch
Rick.
with you, RC.
Hey, RC, I just want to add one thing
Sure.
from everything I've been listening to. So you had a Gleason 6, and
Yes.
your PSA isn't even a 4 yet.
No.
4 is the high range of what doctors look for before they even suggest a biopsy. So
Right.
what I want to say to you is don't worry right now. Pursue the things that you're looking to pursue, but you're a good candidate. In most cases, we would have said active surveillance with what you told us. But since you've gone the way you've gone, pursue what you're pursuing, but don't worry about it too much. Take
Well,
care
you
of
do
it, but
understand that it was over 10.
overly
when I-
stressed.
Yeah.
I'm sorry.
You do understand it was over 10 before I had the surgery, though, right?
Right.
Yeah.
Yeah. Okay.
Right. Here it is. It's Brian Lawenda, Lawenda, and hold on a minute, and I'll put it in the chat window, and I'll send it out right now. There you go.
Got it.
So
Thank you,
that
sir.
So that should be in there. I thought it was with an L. We mentioned a second opinion on your slides. It's probably also a good idea, and I would send that out pretty much right away if it were me. And normally we recommend you go to Epstein at Johns Hopkins. And I'll put that link in, and it should be covered. I'm sort of dubious somewhat in telling you to do that, because will it change your treatment? It was not going to change your current treatment, but it sure would be helpful to know what to do next if we had a better grasp on what was there originally.
Sure.
And so I think it's probably a good suggestion. I'm not 100% convinced, but it just doesn't smell right what happened originally. That's what's bothering, I think, a lot of us on this call is that it just, something isn't right about what happened to begin with. And so we're just trying to figure out where to send you. But I do think that Vogelsang will get to the bottom of it.
Okay.
So I will put in, here we go. Here we go. Copy. And here's the reference for to order a to follow up on a second opinion.
Okay.
Okay. All right. We got to move on to
Sure.
to Mr. Ron Miller, who called me about 3 or 4 weeks ago, and Ron will tell you a little bit about his story, but he has a similar situation to Professor Bill in that his urethra was damaged when he went through brachytherapy, and he's trying to figure out what to do now, where to go next, and that's why I was so hopeful that Bill might be on the call, but these guys will definitely speak outside, and I can't. I'm not making excuses for Bill, but the last 4 to 6 weeks have been pretty rough for him. He's had a couple of these really bad UTIs, and he's going through carboplatin and docetaxel chemotherapy. So every time he thinks he's strong enough and he wants to reach out, and then he has a setback. So hopefully he'll be in good shape. And you should feel free to give him a call. If he's not well enough, he's going to tell you that he's not well enough to speak. So Ron, why don't you tell us a little bit about your situation and see if any of the guys on the call have any suggestions for you.
We can't hear you. Your microphone's not on.
You need to enable your microphone, Ron. In the top corner, there's a little, I'm not sure what you're using, but there's a little icon with a microphone in it, and you need to click on that. It'll be on the side or in the top of the screen.
And if it's red, it needs to be green.
Can you see it? We see you looking for it.
Do you see an icon that looks like a little camera? Because you have your camera on, the microphone icon should be to the left of that.
No, can't see it, huh? I wish we could help you.
You can always call in on the telephone if you want.
Right.
Yeah. So what you might want to do, Ron, is go back to your phone and either call in or use the phone, because you did have a good connection on your phone. We'll come back to you in a minute. What I'm going to do is I'm going to do a quick roll call and see who needs time, and then we'll come back. And also, we have someone else. We have somebody else. Oh, you are.
Yeah.
Are you there?
Yeah, can you hear me?
We can hear you. Fantastic.
Okay. I was diagnosed. Let's back up. I had a biopsy in June, and none of the 12 clips were positive, although they had the potential to be positive. So the local urologist suggested another PSA and a biopsy in 2 months. When we did the second biopsy, which was now August, one of the 12 clips was positive, and it was 8. So when I went to the local people, they looked at radiation, they looked at hormone treatment, and then I decided to go to Cleveland Clinic. I live in Northwest Pennsylvania, between Cleveland and Buffalo, just south of Lake Erie. So I went to Cleveland and saw a urologist named Rick Klein, and he put me in touch. He said, I think we can do brachytherapy for you. And he put me in touch with one of his colleagues. And so I signed up to do brachytherapy in November 20th. Then when I did that, immediately I had adverse reactions. My complaint was that the preparation from Cleveland was in no way, shape, or form my experience. They talked about mild discomfort. They talked about a honeymoon period. They talked about 2 months, and immediately I needed to calf. So to this day, I am 5.5 months out, and I still calf 5 to 6 times a day. So, something that updates you, Rick, is I reached out to Buffalo, to Roswell Park. They got all my information from Cleveland, from my local urologist, and talked to the new patient person. She called over at the clinic, and they said, we can't help you.
Mm-hmm.
We need you to go see a urologist. They gave me 2 names of people in Buffalo, and I already have a urologist.
Where's the key?
So my process has been pretty negative with Cleveland, and I was ready to basically start over with Buffalo and Roswell Park. But now I have to go back to Cleveland, and what my oncologist is telling me is that he wants me to see another urologist in the Cleveland clinic to be tested to see if I can do a urolift.
Mm-hmm.
But in general, I have not been happy with the oncologist because he's not been supportive and sensitive to my situation. And in general, the world-class service that Cleveland Clinic is known for has been no class.
Yeah.
All kinds of situations that I won't go through. What happens is that I'm at 5.5 months. I'm probably 20% able to void on my own. And I feel like Cleveland just wants me to go away.
Do you mind my asking who are the oncologists that you've seen at Cleveland Clinic? Not the urologist, but have you spoken to any oncologists at
Sure.
Cleveland
The
Clinic?
radiation oncologist is named Jay Sitsky.
Okay.
And he's the one who, with Rick Klein, did the surgery. And 3 days after the surgery, I had called in the day after the procedure because I could not get my cath to work. And so by Wednesday night, which was the day after the surgery, I was pretty desperate. At that point, I had not cast and had not voided at all. So I talked to Cleveland Clinic residency. One of the residents, and he explained how maybe I could do it differently. That worked, and I got 1,000 cc's off of the first cath and 1,000 cc's off the second cath. So when my surgeon called me back 3 days later, he said, "You're in the 5%," which evidently meant 95% of the people react better and 5% of the people don't. My complaint has been that there's been no follow-up. Anything that I've had to do, I've had to initiate, including 4 UTIs, of which I have one now. So that's water over the dam. I'm not going to go into that. But at this point, I'm to see another urologist from Cleveland who's going to do a full bladder test, and then another test to see if I qualify for a urolift.
Right.
My complaint has been that the radiation oncologist has just been insensitive to me, has basically not helped. When I needed new caths, I asked him to order them for a doctor's thing. They wouldn't do it. So I'm not going to go all into that. The point is that I got the impression that the reason why I was having needing to cath was because of the seeds and the radiation. But I'm not so sure that that's the case anymore.
So let me start by going to the person on the call who I think probably has the most experience with catheterizing, which is Peter Kafka. And then we'll open it up and we'll talk maybe about some of the issues you're having and see if we can bounce around some ideas for how to find the right doc. Peter, how do you relate to? I should, by the way, add that Ron found us through Shref. Shref recommended that Ron give us a call. Peter, why don't I start with you?
Yeah, Ron, I feel for you. I mean, I was on a catheter for 8.5 months. I closed up out of my biopsy, and that's what triggered it for me. It wasn't even other treatment. So, were you having urinary symptoms like urinary retention before you had any treatment done?
I was having some, but my PSA was not high enough. The highest PSA ever got was 4.6.
Okay. Were you ever on Flomax or anything like that?
Yes, I was on Flomax.
Okay. So you need a good urologist, and you've got to be persistent with this. I even had a urologist at UCSF do a dynamic test on me where they put the camera, cystoscopy, put the camera up, penis and so forth. And the one at UCSF, which is where I got surgery and where I got radiation, I think very highly of them. That was a jerk. He sent me home telling me there's nothing wrong and keep catheterizing.
Yeah, I believe that's the test I'm having in 2 weeks.
I ended up going down to Los Angeles, and I found a urologist that was really on the ball. They did another urodynamic test for me, and they assured me that there was nothing the matter with my bladder. It was the issue was in my prostate. The tumor itself was blocking the urethra. And I ended up, for myself, I ended up getting surgery.
Surgery to remove the prostate?
Yeah. For you, it might be the case. They didn't have the urolift available at that time. This is a pretty new technology, and it might be effective, but I think to find a urologist who's really on the ball, and it might mean going to 2 or 3 of them until you get a urodynamic test where someone knows what they're looking at and what they're finding. Make sure this is not your bladder, that you've got great pressure and you're doing okay, and it's really a blockage that's against the urethra.
A blockage caused by the seeds?
I don't know. That's
Yeah,
something I don't know. Either they stirred it up too much, putting the seeds in. This is I imagine this is low dose breaking, correct?
yeah, I think so.
Yeah, there might be some swelling or something like that. But if you had urinary retention issues beforehand, it doesn't take much to stir that up. That's what happened.
Steve, is there somebody making noise behind you? Getting a lot
Not
of
much.
from your call.
Okay, I'll check my volume.
Maybe it's Rick.
No,
I think
it's
it is
not
Rick.
me.
Okay,
No, it's not.
Yeah. The test that they're doing in 2 weeks from the referred urologist is going to do what you said. He's going to do the camera and he's going to do the full bladder. But what he's told me is that I could be waiting 10 months. In other words, 4 more months before they would be willing to do a urolift.
Yeah, that's possible. That is possible.
Which is totally different than my oncologist said. He said when you get the urolift done, you'll have immediate relief.
Yeah, but urolifts don't work for everybody. They have to be pretty careful. It depends on the size of your prostate and some other factors. It's pretty new stuff, and it doesn't work for everybody. But I'm hoping it works for you.
That's what the urologist that I'm seeing now. I've seen him once, and then he set up the urolift, or at least the testing for the urolift. The other option is the TERP.
Did we just lose Ron?
No, I'm here.
Okay. So, who was it last week that was 2 weeks ago that was talking about a urolift? Does anybody recall? We had a discussion about a urolift just recently, if I'm not mistaken, or was that on your call, Peter?
Well, I have a friend who just went through the process.
Maybe that was it.
Yeah.
Maybe that was it. Does anyone else have any input? Because I'm processing this and I'm getting some ideas here, but I just want to see, does anyone else have any suggestions, input, thoughts on for Ron on what might be happening?
Sylvester, do you have anything to say about?
Well, what he's explaining is quite different from, I think, what I had. Prior to my diagnosis, I've been suffering from a urethral stricture for many years. But I'm not familiar with some of the terms that are being discussed here this evening. But I did have a prostatectomy subsequent to my urethral stricture. And daily, I dilate myself using a French catheter. And I've been doing this for many, many years. But I'm not familiar with the term that is being used here today.
Which term is that, Sylvester? The urolift?
Yes.
Yeah, I think, I'm not sure many of us are, because this is something that is pretty new. It's something that's very new, but I think that what Ron has been doing is the similar type of catheterization to what you were doing.
Right.
I guess my concern is that that it may not actually be a bladder issue, that it may be a urethra issue, and they have to be very certain of that before they might start messing around with the urolift. As I understand it, the urolift is some sort of a procedure which raises the bladder, but I really don't know. That's about the limit.
Uh-huh.
Can anybody explain to us the term urolift?
Yeah, it's a tube that they insert through your urethra, and it has a trigger device on it. And essentially, what they do is they can rotate it 180 degrees, and it shoots a staple-like device into the prostate on one side, and then they'll rotate it and shoot a staple device on the other side, and they'll put like 4 staples or 6 staples into the prostate on either side, so it opens up the prostatic tissue so that the urethra, so nothing pushes against the urethra. That's the way it works.
That's exactly how they describe it.
Look at it on YouTube.
Yeah.
Yeah, you can look at it on YouTube. It's
Okay.
pretty.
Okay, so it's not at all what I was thinking it was. So it's essentially a procedure to open up the urethra. Is that right, Peter?
Yes, correct. I don't know how long they last. I think it's like a metal or stainless, surgically stainless, or maybe it's plastic. I'm not sure, but some kind of staple device right through the prostatic tissue, and it's kind of like those little plastic things that they put on a tag on a shirt collar or something. On what it doesn't pull through because on the other side it's got a thing that doesn't let it pull through the fabric. That kind of.
I think we go back to probably the what you already know is that you need a really good urologist. And the institution of Peter's experience was even at UCSF, he didn't necessarily get the best advice from his original urologist, and it sounds to me like that's the situation at Cleveland Clinic. I also know that if it is solely a urological issue, which it sounds to be, that they're probably right in that Roswell Park may not be the best, because I know that Bill has ultimately gone outside of Roswell Park for his urologist. He now sees a woman who's outside who he likes, but I don't think she's doing a great job for him because he continues to wrestle with these same UTIs time and time again. So the question really is, where do you find a good, reliable urologist in the area that you live? And I always revert to the NCCN hospitals because I think that they tend to have a fairly high level of quality. And other than UCSF, and I do know that they have a bunch of good urologists. That Ann Arbor is probably the other one that's in the region, but it's quite a bit further for you than Roswell Park.
It's about 4.5 hours. Yeah.
Yeah, but I do know that there are good urologists there. I mean, the guy that used to head that department just retired, and he was a urologist. The head of the urological oncology department there, and I could certainly get a name for you over the next 48 hours if you were interested in looking at Ann Arbor. Beyond that, Seidman, and again, I don't know anybody off the top of my head at Seidman, but I can get a name for you because one of the guys on our advisory board used to be, I don't know if he still is, but he used to be on the board of governors for Seidman. and I could send him a note. I've actually been in touch with him the last couple of days, so I could get a note to him at Seidman. I'm trying to think, where else? In Detroit, there are a couple of options in Detroit too that I can think of. But then, if you're going to go to Detroit, Ann Arbor's even closer than to you than Detroit.
Ann Arbor is actually further than Detroit. Yeah.
Oh, okay.
Just a little bit, maybe an hour, 45 minutes. Yeah.
Okay, so what's the name of the cancer center there? Hold on a minute, and I'll tell you momentarily.
How close to Columbus are you?
4 hours. I'm close. I'm not far from Columbus.
Do you have a name there, Peter?
No, not particularly, but I know Columbus has some pretty good university hospital.
Yeah, Ohio State, sure.
Yeah. Does Case Western have a facility?
Case Western is, I think, in Pittsburgh.
No, Case Western is Cleveland.
Okay, all right.
And that's with Seidman.
Okay.
I think they're part and parcel of Seidman. Karmanos is who I'm thinking of. The Karmanos Cancer Institute.
Okay.
In Detroit. I mean, the person that I know there is a GU medical oncologist, so that's not what you need. But I think that they're a good center. I just don't know whether they have urologists on staff, but let me put their URL in the box. Does anybody else have any how to find a urologist for Ron?
The Hutchins in Columbus might have some ideas. I don't know.
Dave Hutchins, you mean?
Hutchins, yeah. Hutchins.
Yeah. Yeah. We could certainly connect you to Dave Hutchins. He's very helpful. I'm sorry that we're really casting around here for you.
Well, it does sound like you're saying that waiting is not an unexpected problem, and continuing to follow the direction I started at Cleveland and seeing what this urologist has to say after he does the testing. But one of you, I don't know if it was Peter or not, said that it wasn't unusual to have to wait until 10 months to have the urolift.
Right.
No, I didn't say that. I find that hard to. 10 months seems like an unusual time to wait procedure like that.
Yeah.
But I'm not a doctor. I don't know what.
Yeah. Again, I've been under the understanding that the reason why I was having the problems was the seeds, but I'm beginning to wonder if that's not the case.
Well, again, there's we don't know, but it's quite possible that the seeds could have caused some inflammation, but there could be other reasons for the blockage, and I think that's what they've got to get to the bottom of, and that's where. So we need to move on, but why don't we leave it like this, Ron? Would you like me to get a name for you at Ann Arbor?
Yes, that's fine.
Yeah. Okay. So I'll get you I'll get you a name from Ann Arbor. Why don't you follow up with Karmanos and see what they say. And I'll also get you a name at Seidman.
Okay. I appreciate it.
Okay. And I'll copy you on both those emails, and we'll go from there.
That'll be great. I appreciate it, guys.
Okay. Okay. All right. Let me identify. We've got a couple of people that called in on the telephone. Who might have called in on the telephone in the last 45 minutes or so?
That would be me.
Oh, Ken?
Yep.
Okay. Well, wait a minute. No, we've got you down. There are still two more. There are two more people that are on the telephone that we haven't identified. Okay. Well, if you'd like to identify, feel free. And, you know, if I could ask everybody, I know there's an awful lot of background noise on this call today. So if you're not on the, you're not speaking and you can mute, that would help us greatly. And we can get rid of some of the background noise. I do promise you it was not coming from my end.
Ron,
So,
Ron,
I think it was Ron.
I just muted you, Ron. So unmute yourself if you want to talk again. But I think a lot of the noise is coming from you.
okay. All right. So let me run down the list of people. We will probably run 10, 15 minutes longer today to get everybody in, depending on who wants to talk. So Rich Jackson, anything for you today?
Status quo for me, I'm fine. Thank you.
Okay. Jake, anything for you today?
No, nothing for me.
Les, anything you'd like to talk about today?
I don't believe so, especially since I've been having internet problems. So I think I'll pass for today.
Okay. Len, anything you'd like to mention today?
No, thank you, sir. Nothing tonight.
Okay. Carl Foreman, anything you'd like to talk about?
Yes, please.
Okay. John Appler, anything you'd like to talk about? John, anything you'd like to talk about?
I think John left quite a while ago.
Okay, that's fine. Jay Curran, anything you'd like to talk about?
Yes.
Okay. Jerry Pelfrey, anything you'd like to talk about?
He might have left as well.
Okay. Peter, anything for you?
Nothing for me.
Dennis, anything for you?
No, no, thank you.
Okay. Sylvester, anything for you?
No, thank you.
Bill Franklin, anything for you?
No, Rick, thank you.
Okay. Paul Frieder, anything for you?
Read that whole thing.
No, I'm good tonight.
Okay. Ken, anything you'd like to talk about?
Yeah, there is.
Okay.
That's your second helping.
And who is that was just said something right there? It was somebody. Who is that?
I think it was Rich Jackson.
No, it's not.
He's on the telephone.
No.
We're going to mute you because you keep
talking.
Well,
hold on before we mute. Is there anybody else on the call who would like to say, who has a question that I haven't asked? Okay. So our mystery person, I think we can mute since we don't know who they are and they don't want to ask a question. So we're going to mute you. Well, I'll unmute you in a few minutes in case you'd like to come back and identify and you do want to ask a question. But please feel free to stay with us and participate. All right. So yeah, it looks like we lost Jerry Pelfrey. Okay, so why don't we start off with Carl Foreman, then we'll go to Jay Curran, and then we'll go to Ken Anderson.
Okay. First off, to share some good news, I had my latest oncologist and surgeon's appointment last week. They did some blood work. This was also after I've had completed Provenge treatment about 2 weeks ago and was changed onto olaparib, the PARP inhibitor, and I've been on it about 2.5 months. So the PSA is 0.02, the lowest I've ever had, and I hope it will continue. Thank you. My oncologist, when I asked him, well, how long can we expect it to be useful, the PARP inhibitor, and he says a year to 18 months. So we'll see what happens with that. The second item I wanted to discuss is that earlier today, I received an updated email from Color Genomics. Those of you who've had genetic testing through Color Genomics, if anybody here is on the call, and that is with the saliva test. So apparently they've updated their testing, and there are some additional genetic mutations that have been reviewed, and there's a report. There's 14 additional genetic markers that they now have included in their report. So I really haven't had a chance to go into detail of what the report says, other than I've made an appointment with their genetic counselor, which is available for next week, to discuss those results. So just curious to put it out there if anybody else who's had the color test and have gotten the latest email from them.
Carl, I had the color test and I just checked my email, but they didn't send me anything.
Okay.
And anyone else who had the color test on the call tonight? Peter, yours was Ambry, wasn't it?
Yes, Ambry.
Yeah. So at this point, Carl, have you don't know if they've identified additional mutations for you or not?
Well, they have. Looking at the report now, it says we analyzed 14 genes that can affect how individuals process certain medications. And they divided into 2 categories, metabolizers and non-metabolizers. So, you know, there's something called CYP1A2 and CYP, a number of them with the CYP designation. And there's different, and they have a column called genetic interpretation. They run from rapid metabolizer to intermediate metabolizer to normal to ultra rapid to poor. Those are the type of interpretations. So I have to drill down further exactly what they mean. For non-metabolizers, they have 4. There's something, it says there's a variant absent, there's an unfavorable response, and 2 others say decreased function. Again, sorry I haven't had a chance to look into greater detail, but
that's okay.
That's what I've got to report here.
Well, I mean, I'm sure that after you've spoken to them, you'll give us another update, but are you saying that they've reported 10 additional mutations to you that in some way, shape, or form affect the way that you metabolize drugs?
Yes. And let me just go to the original email. It says here, we want to let you know that the results for the 12 additional genes in your medication response genetic test are ready, in addition to the results for the 2 genes you received earlier. So, and they were also sending it to my primary care doctor. But
and when they say the 2 genes you received earlier, that was BRCA2 and was it ATR?
Well, P10.
P10.
And
right.
There were no number of others, but
yeah. So that's why I'm wondering why they say 2. Because I've got several down: BRCA2, P10, ATR, Tempress, and TMB4.
Sounds familiar, yes.
Yeah. So
was one of them RB1, Carl?
No.
Okay.
Okay. So when you get to the bottom of it, you'll let us know. But I think that the bigger news is that the olaparib appears to be working for you, and that's pretty spectacular.
Yeah. And what's also interesting, the comments from the surgeon who did my robotic prostatectomy back in November, when he saw the results, he was amazed. And he said, boy, I'm going to have to talk to your oncologist and find out, first of all, how he got you the medication, because typically you can only get it in trial. And we talked about it here on the forum, where my doctor made a special request from, I think it's AstraZeneca is the pharmaceutical company, to be able to allow me to use it. So, I've had no out of pocket on it.
Right. Now, I mean, I just was contacted by a doctor who is BRCA positive, and he's having trouble, and he's on Medicare, he's on the United Healthcare supplementary program, and he says he's having trouble getting olaparib. That he got it for the first year through AstraZeneca at no cost, but they're only giving it to him for a year, and now United Healthcare won't approve it. But I mean, I do know in the past we've had several people who are BRCA positive who have had no problem at all getting a PARP inhibitor, including Bill. So whether they're just making it more difficult now, I don't know, but I seem to feel that that you can make a pretty good case. Your doctors can make a good case to the insurance companies to prescribe off-label, particularly if you are germline BRCA. Probably more so if you're germline BRCA than if you're somatic BRCA.
Right.
But I mean, he should not be surprised in any way, shape, or form, the surgeon, that you responded. I mean, he should be surprised. If it's a surprise to him that you responded, I'd be a little worried about Dr. Kim. Isn't that his name, Dr. Kim?
Yes, Dr. Kim.
Okay. So I'm digging into my memory here, Carl.
Yeah.
Now, I can tell you that 18-month figure is anecdotally what we've seen here with Bill, and I think I'm trying to remember who the other person was. There was one other person that it worked for quite a while, but you just don't know. Everybody's different. I just listened to a presentation. Who was being interviewed? Dr. Yu from Washington was being interviewed at the PCF conference, and they were talking about the Triton and the TOPARP results from the trial, and what they seemed to think was that ATR had little impact for PARP inhibitors, which is kind of interesting because in the past people have said, well, ATR is in the pathway, and I think was ATR Len? Was ATR was that the mutation that Dominic had?
I think he had CDK12.
Okay, yeah, he could have been CDK12, yeah. But anyway, as far as you're concerned, hopefully it'll still keep working. Hopefully you'll still get it through AstraZeneca. And when you don't get it through AstraZeneca, your doctors are going to be able to lean heavily enough on your on your insurance company. Who carries your secondary?
I'm not yet on Medicare. I will be in November. I'll be turning 65, but I have Optum RX is the pharmacy, and that's through Horizon Blue Cross Blue Shield.
Horizon Blue Cross Blue Shield. Well, you know, you're our insurance maven, but the one thing I think that you probably should be investigating when because you can go to anybody for your secondary, and United Healthcare, in my experience, has always been really good. But you do want to be looking at who's going to be willing to give you that PARP inhibitor off label.
Right.
In determining who you pick for your supplementary policy.
Yeah, I still have about 7 months for that.
Right. Obviously, yep. But for you, that'll be a big factor.
Absolutely.
A very big factor. But anyway, anyone like to talk to Carl about either of the two topics?
Well, Carl, it's Len. Congratulations on olaparib working so well for you.
Thank you.
The report you got from Color about your being you are a poor metabolizer? Is that what they?
They have they divide into two sections: metabolizers and non-metabolizers.
Did they tell you anything about the significance of that regarding the drugs that you take?
Well, you know, there's I have to drill down into each of the categories to see what it is. I just, you know, I got it earlier today, so I don't have much info, unfortunately, right now.
Okay. Well, maybe next week you can tell us.
Yep.
Okay. Any other questions for Carl before we move on to Jay Curran?
Oh, yeah, just one other. Carl, are you still taking Zytiga, or did you stop?
No, the Zytiga failed, and that's when they switched me to the PARP inhibitors. So I was on Zytiga with prednisone for 6 months. I continue to be on Eligard and Xgeva for the bone.
Okay.
Okay.
Okay. Good luck.
Thank you.
Okay. All right. So let's move on to Jay Curran. Jay, how you doing on that BAT?
Well, my doctor says I'm doing all right, but I've gotten 2 increases. I went from 791 up to 882, but I started at 2588. So neither one of my doctors seems to be too excited about the increase, Dr. Agarwal or Dr. Lee. But that's my situation right now.
So I'm just making some notes here. So let's see. The last time we spoke to you, you were at 656. So what we've seen since then is 791 and then 882. Where are you in the cycle right now?
I've done 3 cycles. I'm on my 4th. Think I got that right. I stopped etoposide. I'm not taking that anymore.
Okay. And how are you feeling in yourself?
I was offered a blood transfusion about 6 weeks ago, and I accepted it and took that. It did not kick in right away, but after about 2 weeks, I started to feel better.
Okay. And what's going on with your blood counts?
They're not great, but neither doctor seemed to be worried about them.
So where's your hemoglobin?
I have to look that up, but What are the ranges that it usually runs in?
Well, when it gets below 10, it's sort of a flag, and if it gets below 8, it's usually means that at least one infusion, and if it gets much below 8, it's a problem. Is that right, Len? How am I doing?
You're doing well.
Okay.
Actually, that reminds me, didn't Peter, hemoglobin drop to around 8 something? I wonder, Peter, how are you doing with that?
It dropped to, I think 9.3. Maybe it went to 8. I can't remember. But it's back up to 10 now.
Oh, good.
10.
Okay.
So I was happy.
Good. So where are you, Jay?
Well, I have to go dig, but I can give you what happened on when I had 791 reading. My hematocrit was at 29.1, which I think was a result of the blood transfusion. Platelets were at 75, and white blood cells were at 7.6.
And what about your hemoglobin?
I don't know.
Rick, as a general rule, the hemoglobin is 1/3 of the hematocrit. So if his hematocrit is just under 30, his hemoglobin is probably just under 10.
Okay. Thank you. That's a good little trick. I didn't know that one. Okay. Yeah. Okay. Thank you, sir. So yeah, the hemoglobin is the one that I think I go by, and a lot of folks go by, but now we know how to get to that hemoglobin from the hematocrit. What's on your mind? Tell us what other than the update, what can we do?
Well, you folks are communication experts, and I've been trying to get through to Weill Cornell without making a 3,000-mile trip there, just to ask them, would they accept me in a phase 2 LU-177 trial if I have turned down chemo and radiation?
My gut is that they would not, because they're fairly strict about this. And does anybody on this call remember, first of all, is there anybody on this call who goes back to the early days of the Reluctant Brotherhood phone calls? Len?
Yes.
Do you remember Yoda?
Oh, no.
You don't remember Yoda. So Yoda is a guy called Steve Ruckline who lives in Minnesota and was always active in the Reluctant Brotherhood and also ran an US2 group in the Minneapolis area, and who never wanted to do chemotherapy or radiation. And his disease, he didn't want to do anything. Eventually he did brachytherapy, even though he had quite advanced disease. And then his disease came back. And then I just found out this week that he's over in Australia doing a lutetium trial, because they are willing to accept him into the trial, having not done any of the prerequisites. But have you tried to speak to the trial coordinators at Weill Cornell?
Yeah, I got their names, and they say send all your medical records in, and then we'll talk to you. And so I guess that's what I'll have to do. But I thought my questions are pretty simple. My 2 questions to them.
Okay, so in other words, you'd like to talk to them to ask them before you send in your medical records.
Yeah, I would like to, but I'll do it if I have to.
Well, if it were me, I think I'd be wanting to send my medical records in, because they may make an exception for you. Whereas
I hadn't thought of that.
Huh?
Okay, I'm glad to hear that.
Well, I can't say they would, but I think you've got more chance if they're looking at your history versus you speaking to a couple of people on the telephone. I mean, who else has some ideas on how Jay might be able to get into that Weill Cornell trial or any other lutetium trial that requires treatments that he has not done?
I don't want any. And then he comes and starts saying, well, what can I do on that? Then,
so, anybody got any ideas for Jay?
Well, Jay, I think that unfortunately, I think they do require the chemotherapy prior to admittance. Whether or not they'll let you into the trial as an exception, I think is unlikely because they usually need to strictly adhere to the trial protocol. If the protocol calls for chemotherapy, I kind of doubt that they would let you in, but like Rick says, you have nothing to lose. But I would try and get Dr. Scott Tagawa's email and or phone number, try and talk to him directly and just say, look, I don't want to go through all of the hassle of getting all of my medical records to you if you're only going to tell me I'm not eligible because I've never had chemotherapy. You know, maybe he'll tell you right bluntly that, yeah, don't bother, or we'll go ahead, send it in, and we might consider you. But you really, you should be able to at least email Tagawa, if not speak to him.
Okay.
I'm stating this because a few years ago there was a trial that I was thinking about getting into, and I sent him an email, and he responded within a day. So hopefully you'll have the same luck.
Okay, I have to dig deeper and get his email. I did look on the website, and I got emails for other people, but not to him, and I did mail them. Okay, thank you.
Well, you know, a little trick is that if you've got emails for other people at Weill Cornell, just follow the protocol. So, you know, if they were set up as S, you know, it might be S period Tagawa or Scott period Tagawa, whatever the protocol is, do the same thing and see if it doesn't come back to you, it got through to it.
Okay.
You know?
Yeah.
Oh, Jay, one other thing. I'm going to a lecture on May 12th at Weill Cornell. I'll see what I can find out if you can afford to wait another 6 days.
Yeah, I have an appointment with them for May 22nd. I said I might have to cancel it, but I do have an appointment. They wouldn't talk to me until I said I'd get an appointment.
Well, why did you pick, I mean, you know, there are several lutetium-177 trials around the country. Why did you drill down on this one at Weill Cornell?
Well, it looked like I could get into those two phase 1 and 2 trials where everything else seemed to have the requirements that I would not meet. My local doctor here, Dr. Iowa, he put me in the queue for one phase, I think 1 or 2 trial on lutetium, but he didn't recommend that I do it right away because he said that the dosage would be so small that it may not help me.
But I guess I'm confused. I thought you said that Weill Cornell has a prerequisite of radiation and chemotherapy.
Well, it didn't have it on those 2 trials, phase 1 and 2. It's called low dose escalation trial, LU-177, J591, and one other one.
So why don't you just apply for those trials if it doesn't have it? I'm not sure. I'm confused here. I thought you were you couldn't get into the Weill Cornell trial because it needed radiation and chemotherapy, but now the trial you want to get into doesn't. Am I the only one that's having trouble here? Len, are you confused or not?
I am, but I'm frequently confused, so don't go by me.
Well, I'll have to go and look at the website again, look over my notes, and I'll figure it out.
I mean, I wish we could help you, but I'm not sure, I'm not sure what to say to you. I don't know. Anybody else have any ideas for Jay? Help. No? All right. Well, Jay, let's keep talking. You know how to get a hold of me. And maybe Len will come up with something. But essentially, Len, what he's looking for is in lutetium-177, where he has not done radiation or chemotherapy.
That part I understand.
What lecture are you going to?
Dr. Susan Slovin of MSK will be talking about the cardiovascular risks associated with hormone therapy.
Oh, right. I thought that was us too. Is the us two meeting held at Weill Cornell?
Yes.
Ah, okay.
Which is just down the street from MSK.
Yeah, that much I do know. So yeah, that much I'm aware of that part. Okay. I'm just making a couple of notes. All right, I think we are on to Ken. Open up that microphone, Ken.
All right, Richard. So I'm sitting here with Cameron. We're on a road trip between LA and San Francisco. We're in Morro Bay.
Get out of here. When did Cameron come over?
Yeah, he flew over about 5 days ago. We spent, 5 days kind of beating around Los Angeles, went to Catalina, and just had a good time.
Wow. Well, Cameron, yeah, we're not going to let you go without talking to these guys. I think you've been on the call once before, but just
I've been on a couple of times. Hi.
Hi. Just introduce yourself to the guys.
Hello, everyone. Just briefly, 45-year-old with metastatic castrate-resistant prostate cancer, living the dream.
No, a nightmare. Not a dream. Not a dream.
Well, you wanted the condensed version. There you go.
Oh boy! Hey, so you got a pass from the wife and kids to come on your own, Cameron?
Yeah, it was hard work, but 11 days in total I'll be away from the family. So at the moment we're driving a very fast Corvette. So life is good.
Whoa! And where did this fast Corvette come from?
Rented.
Rented. I don't know. If you would have come through Arizona, you might have convinced Dennis Correa to lend you his Correa. What his Carrera? What is it? A 917, Dennis?
Porsche 718.
718. Cayman S. Excuse me. Cayman S. Yeah. So okay. Well, there's a great taco place just north of Morro Bay, and I have it bookmarked. So
I know where it is.
Oh, you know it?
Well, it's a Mexican restaurant that has tacos. Yeah.
Well, actually, no. I didn't think it was a Mexican restaurant. They have smoked fish in there, and you can buy the smoked fish to go away. It's called, hold on a minute. I see, I'm sure I bookmarked it because I looked it up for somebody just recently. Smoker Jim, Ruddles, Ruddles.
Ruddles. That's not the one I was thinking of, but we'll look it up. And we're looking for a place for dinner because it's that time of the day.
Yeah.
So the question to the group.
Yes.
You know, and we put the question on Inspire as well. We have an appointment for Cam to see Peter Mack. Actually, Ben set it up. His doctor in Melbourne. We have an appointment to see Mr. Wong for Provenge. What do you think, Rick? Your wheels are turning.
So hold on a second. Who is it that which doctor is it that you're going to go see for this?
UCSF, Wong.
Larry?
Larry Wong.
Wong or Fong?
Fong, sorry. It's a little slip of the tongue. It's Fong, not Wong.
It's Fong. Yes, you were, I hate to tell you, but you were Wong on that one.
Oh, bang, bang.
Well,
more interested in just Provenge in general. You know how Paul at MD Anderson thinks what he thinks about it, you know, and I don't know.
Well, first of all, well done for getting an appointment with Larry. How did you do that? Tell us.
So my medical oncologist in Melbourne, I said a few months ago, well, what about this Provenge that it's only available in the US? And so he got me onto him, and it just so happened that I'd already booked the holiday with Ken. So it was a meant to be sort of meeting. Okay.
Well, it's great because it's very, very difficult to get an appointment with Larry these days. So I think, so when you see him, you can give him my love. And I actually saw him on some presentation, and I was going to send him a note, but he is one of our all-time favorite doctors. And carry a message to him from me, Ken, will you please?
What's the message, as long as I can repeat it?
The message is, don't forget to invite me to the opening of his new center with all of Jerry's paintings, because they took 18 of Jerry Cornelia's paintings, and they're going to be displayed in the new cancer center, the Immuno-Oncology Cancer Center that is going to be opening later this year. And so
you'd like an invite.
It's very exciting, and hopefully they will remember us and send us an invitation. And there isn't any better to talk to about Provenge, because he was the principal investigator for Provenge. You know, his issue with Provenge, I think, is that the tumor burden has to be low enough, and he will determine what that tumor burden is, and you know, tell you based on that whether he thinks it'll work. But if I was seeing Larry right now, I wouldn't be focusing in so much on the Provenge as I would be on what immunotherapies are available for you, because he's probably one of the best people in the United States to be talking about immuno-oncology for prostate cancer.
Well, excellent.
So that's where I would lead the conversation with a backup.
How much time do you think you'll give us, Rick?
Well, since you come all the way from the other side of the world, you might get a good half an hour.
Excellent.
I don't even know whether he's going to let Ken in, to be honest, because the appointment's me. It sounds very like it's pretty hard work. I've had to fill in more forms than you could poke a stick at.
No, he'll let Ken in. I never had a problem going in with any of his patients. I probably went in with 3 different patients and I never had a problem.
Well, that'd be good.
So provided that you are together, I'm sure that that he'll let you in. He's wonderful. He's incredibly kind, compassionate, and super smart. So, you know, it's always been sad to me that he's not taking new patients, because I haven't been able to get anybody to him for a while. But by all means, the both of you go in, and I would strongly suggest you talk to him. Now, he just did a presentation on Cure Talk with a couple of other people. John Nowak was on the panel and a couple of other people. It wasn't specifically about prostate cancer, it was about immuno-oncology. He did that, I think, beginning of April. You might want to listen to that before you go in. I'll try and find the link for you. And
I saw the link, Rick. I saw the link. I have it.
Okay, so listen to it before. That's where I just heard him recently. So just go in, and we have a recording on our website that he did. So it should be on the new website.
So could you think of anything specifically that you would ask him in regards to immunotherapy?
Well, yeah, I mean, given, have you had any genetic testing done, genomic testing or genetic testing done, Cameron?
Well, I've had the cancer panel. I don't have any of the BRCA or anything like that. I've got P10 loss and a few other things like that, but nothing that my medical oncologist said stood out at this point in time.
Do you have those results with you that you can show him?
Larry will have pretty much everything by the time I arrive. My oncologist has also downloaded scans for him and everything.
So, you know, I think I would be asking, and let me ask you, was that panel taken from your tumor?
Yes, the original tumor, yes.
From the original tumor. And how long ago was that done?
I had the radical prostatectomy on Feb 1, 2017.
So, you know, he may be, that's 2 years ago, and we don't know how your disease could possibly have changed over those 2 years. And, you know, 2 years is a long enough time that there could be some changes. So don't be surprised if he says to you, you know, you might want to get sequenced again. But I would ask him about what he sees on that sequencing.
Okay. Yeah, I did raise that with my medical oncologist about having it done again. But I'll raise that again with Larry. I mean, the main focus of actually, like, this was not time to come and see Larry, but the main focus was that I was interested in ProBench only because, you know, I'm at that point in time where what is the next treatment? I've had so many things done, but I've got a low burden. My PSA is 0.067, but it's rising on bicalutamide, and, you know, we've got to do something now rather than sit and do nothing.
Cameron, how would you handle the logistics of ProVeg?
It'll be an absolute nightmare times 50. I don't know. I will literally have to fly over from, I don't know where it gets done. If it's San Francisco, I'll get a flight from Melbourne to San Francisco 4 times, or otherwise stay here for 5 weeks. I don't know.
Three times. I mean, you'd have to come back and forth 3 times, 2 weeks apart. But let me. Do you know what your microsatellite instability is? Your MSI, was that measured in your cancer panel?
No.
Okay. I mean, do you know any of your, you know, whether you are, whether you have PDL1? whether you exhibit PD-L1 or any of those issues, the types of measures that would make you eligible for something like Keytruda, pembrolizumab?
I don't think I don't know that myself, no.
Okay, so those are the sorts of issues that you want to be talking to him about. You know, whether you have any MSI, whether you have any mismatch repairs, whether you have any of the factors or what tests you should get to find out if you have any of the factors that some of these precision immunotherapy drugs would key in on.
Yep.
Len, do you want to come in on this?
Well, the original comment on the original question, which was my opinion of Provenge or something else.
Well, no,
of course, let's have that.
What was that?
I said, of course, let's have that, Len.
Yeah, so I'm in favor of it. It's well tolerated, and it works best when the tumor burden is low, your PSA is low. So the earlier you use these immunotherapies, the better. I think this is an ideal time to get it. And although the clinical trial way back when reported the median survival, overall survival was an additional 4 months, those were very advanced disease enrollees. So they've been tracking this over time, and it seems like the overall survival for folks with PSA less than 22, I think the number is, overall survival improves by 18 months. And that number seems to keep growing as they keep following these guys.
So as an Australian, my skeptical self says, why has this great immunotherapy drug not been expanded around the world and is just stuck in America still?
I think the problem with Provenge is that they have a difficult time finding the right marker to prove that it's working. So you probably know it doesn't really affect PSA much one way or another. There are a bunch of theories about how it might work. But in my view, you can't argue with the statistics that show that if you get this therapy before your tumor burden or before the immune system gets overwhelmed with a large tumor burden, it's going to have a meaningful extension of life of 18 months or more, possibly.
Well, that's really important to someone like me with a 10-year-old, a 7-year-old, and a 5-year-old. I mean, I'm only weighing it up for a logistics and a cost basis. Because 4 months versus whatever it's going to cost me in money and time doesn't sound as great as 18 months, obviously, when I'm 45 years old. But
oh, okay.
I mean, certainly.
Hey, Lynn, do you have
18 months does sound like
that? Do you have that, Lynn, that you could send forward, that piece that you're referring to, or do you know where it came from?
Yeah, I can send it to you, Ken.
Okay. It'd be nice to kind of review it. See how many guys were in the trial and, what it came from, whether or not it came from the company that now owns Provenge. Provenge has only been around 12 years approximately, so there's another 8 years before it goes off. Is that correct?
I don't know what the patent life remaining is. I think it was approved in 2010.
Okay.
There are all kinds of factors that impact patent life.
That doesn't really matter so much, but thanks. It really doesn't, I guess. It's a pretty big decision, but I'm glad he's got the appointment if Fong's a great guy, Rick. So.
Yeah, look, here are a couple of things here. The first is one of the reasons why Provenge hasn't expanded the way that you would like to see it expand, Cameron, is because Dendrium was underfunded. It never had the resources, and the issue with Provenge is that you've got to have a lab, and the blood has to be processed and inoculated, and it has to get there and back in a very short period of time. So it doesn't make sense unless there's a significant demand. And so to put these issues to expand the way that it's being expanded is the way you'd like to see it expand requires a lot of capital. And now that the Chinese are looking to expand, and the word is that they're going to expand in the Southern Hemisphere. I heard that last year sometime. So, you know, I think that's probably the biggest reason why we have, as Len said, the original trial didn't show a huge benefit, but it was done with people with very late stage disease, and they haven't had the capital and the money to do additional trials to show that it's much more effective when given earlier. And so it's just sort of languished. But the person who will tell you the most about it is probably Larry Fong, because he understands it better than anybody. My issue would be, is it the best treatment right now? It might be one option and it might not have much downside, but I don't know that it is the most optimal treatment. And
Cameron,
that's what you got to dig down with Larry, and try and find out, if you were his patient, what would he recommend in terms of in the immuno-oncology field for somebody like yourself right now?
Well, that sounds like good advice. I mean, my current medical oncologist path is to keep me on bicalutamide until my PSA reaches well, we haven't agreed to a point, but then either look at abiraterone or enzalutamide, and then the list gets shorter and shorter. So the current trajectory isn't too flash from my perspective, hence why I'm wanting to look at something a little bit left of center.
Well, but look, it's difficult to talk to you in the sense that I'm never quite sure what's available in Australia, although I do think that apalutamide was just, if I'm not mistaken, apalutamide was just approved.
I think for non-metastatic castrate resistant.
Right. And yours is metastatic castrate sensitive, correct?
No, I think it's metastatic castrate resistant now.
So have you've seen 3 successive increases in your?
I had 3 successes. I had 3. I don't know if I had the bilateral orchiectomy. So
Right.
after that, I had 3 successive, very small, but increases that were sufficient for me. Like my medical oncologist put me on bicalutamide. So that was back in November last year after small rises. That dropped it down to a low again of 0.051 or something like that. And then it's just gone up again twice. So from 0.054 to 0.067 over a 14-week period. So it's not taking off, but
but it's increasing.
In there that's moving.
Right. Well, I mean, and so far you haven't tried any second-line anti-androgen. Is that right?
No, and I think my oncologist's idea with everything that we've done so far is to hold on for as long as possible. I mean, if you actually looked at me, I'm physically fitter than I was 20 years ago. So it's more about how do I keep myself in this situation now with the cancer of having low burden, no metastases showing on PET CT scans, but a slowly rising PSA. I'd like to keep that there for a long time, but unfortunately, I thought the bilateral orchiectomy would keep it there longer than what it did.
Well, you know, I think you've got to lay that out, lay out your objectives to Larry up front, and, you know, say to him that you're willing to consider Provenge. I mean, he's going to talk to you about second-line anti-androgens, because that would be the natural next step. And as much as you'd like to talk about immuno-oncology with him, probably other than the Provenge, he would be thinking that most of the other stuff is further down the line after you've done the second-line anti-androgens. You know, so I'm
that's
sort
okay
of,
as long as I've got the foot in the door with Larry. So, I mean, I just like to have my options, many of them. I need a lot of them.
Right. And I mean, as Len said, for somebody like yourself, now might be a really good time to do the Provenge. But again, I think I trust him so much. I would be saying to him, look, if money is no object, what is the best course of treatment? Lay out a treatment plan for me that my guy in Australia can follow. Tran, right? Are you still with Ben Tran?
Yeah, Ben Tran.
Right. So, you know, what is the best course of treatment that we can follow if money were no object? But, you know, would you do the Provenge now? Would you do the Zytiga first? Would you do Elida first? Would you do Xtandi first? You know, what would you go with? And I would follow him. I think he's the best. If I had to pick out one guy to treat me, that's who it would be.
Well, you've made my day, Rick. Thanks.
No, I mean,
we're seeing him tomorrow.
No, we're not. Right.
Right. I mean, I love this guy. I mean, he's the best. He's really the best. He's just not easy to get to anymore. Yeah. Well, let me know. Ken, give me a call after you see him. I mean, tell him give him a big hug from me and tell him I said hi and let us know what he suggests. But I think the objective should be, it's really hard to say, Cam. I mean, some of these precision medicines, these immuno and precision medicines are very appropriate if you have the right mutations, but you may be too early in the path for that.
Well, I think it's good to have sorry, Len.
Yeah, I just wanted to mention, I had just read something in a PCF flyer, I think I get it monthly, talking about Larry Fong and some protege of his who have a phase 2 trial that they're really enthusiastic about using Keytruda, pembrolizumab, plus something fairly new, an immunostimulant called SD101. Talk to them about that, because that sounds like, I guess it's high risk, but it sounds like it could be a home run if it's as good as they're talking it up to be. Powerful immunostimulant to get the.
I saw my first baseball match the other night, so a home run would be perfect.
Well, we went down and watched the Angels in Anaheim.
Oh, I thought you took him to see the Diamondbacks and the Yankees.
Nope, nope, nope.
Thank you for that, Len.
Sure.
Yeah. Yeah. So what is that, Len? It's something called SD101 and pembrolizumab?
Yes, a phase 2 trial. He seemed he got PCF funding for it. They're very excited about it. It seems to be a pan cancer application for this SD101.
Okay.
To be used with checkpoint inhibitors. You know, I don't know how much of it is hype because it's PCF publication and they're funding it, but it really sounded pretty exciting.
Okay. Well, thanks for that, then. All right,
guys.
gents. That restaurant Ruddles is in
Cambria.
Is it Cambria? Oh, you found it already. There you go.
No, I'm guessing that's where it is, because it seems like that's where all the Mexican places are.
But this isn't a Mexican place. This is a fish food place. I don't think it's I'm just looking. I'm looking to. I've got the website open right here. So I'm looking for the address. Hold on a minute. It's just bringing up where's the address? Oh man, it's got everything on this. Oh, here it is. Cayucos, that's it. C-A-Y.
Yeah, I know where it is.
Okay, Cayucos, that's where you want to go. Ruddle Smokehouse, Cayucos.
For my nephew said there were no restaurants there.
You're talking to the wrong person, Anderson. You know you should have called me.
All right. All right.
Wait, can I just give Jay Curran the email address I have for Scott Tagawa?
Of course.
So Jay, you're on the line, right?
Right.
Okay, so it's STT as in Sally Thomas 2007 at med.cornell.edu.
Okay. And I had a word to say about Provenge if we got time, but just a couple words.
Go ahead.
Had me go on it before I took Zytiga, and I think my PSAs were up around 1,700 when I started therapy in 2016. So even though it's a background drug, I guess he thought it might do me some good. And I went on Zytiga afterwards, and my PSA did drop about 100 points from 100 to about down to 5 in about 5 weeks. And if you need a room, I might be able to get you one.
Well, that's very nice.
I live in San Francisco. Go ahead.
Thank you. Okay, guys, anybody else want to say anything to Cameron before we lose him? I didn't mean it like that, Cameron. Before we
thanks, Rick. I love the vote of confidence. I've got a couple of years left in me, apparently.
Sorry about that, Copper. I didn't exactly mean that.
That's all right, mate.
Hey, Anderson, what about you? Any news on you?
You know, I must admit, I had labs done last Monday, and for criminy sakes, I don't have the results yet.
You see, this visit from Cameron is the best thing that could happen to you.
Oh, really?
I can look at it. Look, it's doing wonders for your mental health already. I can see it. Okay.
Oh, that's true. That's true.
Okay. All right, guys.
All right, you guys. Thanks for your time.
Have fun. Take him to Farallon. Go have Go to Farallon tomorrow between 4:30 and 6. They have a fantastic happy hour. It's an amazing restaurant.
Farallon, San Francisco, yeah?
Yeah, Farallon. 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 Okay.
All right.
Okay.
Just to quickly throw in, I just checked the PCRI conference is scheduled for September 6th to 8th of this year in Los Angeles. So I expect to see you guys there from ANCAN.
We'll be there.
Okay.
All right.
Good night.
Okay, guys.
Good night.
All right. Sorry we went on a little long, but we were not expecting a special guest, and that we got right at the end. So there you go.
Well, thanks for taking the time.
Pleasure. Okay. Good night, everybody.
Good night.